So my name is Adam Brown. I'm a physiotherapist. I've held lots of different roles as an advanced practice clinician. I'm the founder of Cornerstone Physiotherapy, a research associate with UHN, and have been interested in diving into what role rehab plays in recovery from post-viral illness since 2020, when it became a clear priority. Not that it wasn't before, but certainly it expanded in 2020 for obvious reasons. The link on the screen is a link to our webpage that can tell you a little bit about the program. So the purpose here is to talk a little bit about some of the newer research and understanding of energy systems in the context of long COVID. In in particular, the context of long COVID, where people have the MECFS type phenotype, meaning that they experience post-exertional malaise, which is that worsening of symptoms that can occur after cognitive or physical exertion, and there can be a delay in between. And so, crushing fatigue, a worsening of their usual symptoms, and those sorts of things that can last for a while. We've learned, um, we've begun to learn a bit about that, and it's beginning to inform how we try and help people. And so I think it's worth covering. Again, it'd be great if it were interactive. If you guys have anything to say, questions or comments, and we recognize that uh, lived experience have an enormous amount to teach us, and so I'm very much happy to hear people's comments. We did receive some question in advance, but absolutely feel free to speak up. Um, And here I just want to pause for a moment just to say that long COVID is a very wide diagnosis, meaning that there are individuals with very different mixes of syndromes. And the dominant syndromes that sit under that larger umbrella that we call long COVID are the MECFS phenotype, mast cell activation, POTS, other forms of dysautonomia. And so, whenever we're talking about long COVID rehab, the first step is to assess with this individual which of those syndromes apply and choose strategies on that basis. That's why one size fits all just really doesn't work. And so, questions around how do I get my long COVID symptoms to go away? The only reasonable answer I can give you to that is it depends. And so it's very much a personalized approach. You may, to that end, in this chat or any of our subsequent chats that we do, you may see yourself, you may see some of your own symptoms, and you may not. And it just depends on what mix of symptoms you have. We do have an upcoming talk that focuses on mast cell activations, foods or other stimuli that create almost allergic-like or inflammatory symptoms. Our two dietitians are doing a talk on that, and they've had a wealth of experience in trying to help people with that. Vi will just drop the link to that in the chat for those of you who are interested in attending that particular talk. Systems. This is something I wanted to cover because I think it's exciting what has happened and what is being shown in the long COVID population. There was some foreshadowing in the MECFS population of this, but the fact that long COVID has become a more widespread issue has sort of revitalized research in it. So the three papers that I have up here are key papers that show basically quantify the mitochondrial dysfunction or the energy production dysfunction in individuals who have that MECFS phenotype of long COVID, or the chronic fatigue that leads to post-exertional malaise, or those crashes, if you will. Basically, the main impairment seems to be in fatty acid oxidation, which is the largest store of energy that we have in our body, is when we utilize fat in order to produce energy. Um, and also reduction in our ability to use lactate, which is a byproduct of carbohydrate um, oxidation, or carbohydrate, the use of carbohydrate to produce fuels. And so really these changes at the energy production level are beginning to be quantified and understood a little bit better. Now, the last paper is one that is done in people with ME/CFS, not necessarily long COVID. But I can tell you that some of our advisors who are researchers in the space have reproduced this finding with individuals who have long COVID. It's just pre-publication at this point. But what it shows is that on cardiopulmonary exercise testing, which is a procedure whereby we measure with exercise which substrates or what fuels the body is using at different intensities of exercise, to learn a whole host of information about how their metabolic system works and how well they can produce energy. When we look at a 2-day, so we do a CPET test one day and a CPET test the next day, we get very, very different results on the second day, which is an extremely interesting finding, which we would not expect in a group of healthy controls. And what that finding is that the threshold where the body shifts from utilizing fat to produce energy over to utilizing carbohydrate to produce energy, it changes. And so while if you were to test a healthy individual, those two tests, that point would be relatively the same point every day. What we've learned in that ME/CFS community and in the long COVID community is that when an individual is experiencing PEM, their fat oxidation, or their ability to tap into fat to produce energy, is at much, much lower intensities. That shifts over. And so you can imagine that even just things like standing up and walking around have you shifted over and utilizing carbohydrate as your energy source, whereas normally that would be reserved for more intense activity. I just want to pause there for a second and ask, are there questions about that CPET or that finding? Because I know sometimes, again, I have this tendency to utilize terms that might not be totally clear. And I don't know everybody's level of sort of background knowledge, but I want to give an opportunity for people to throw up a hand if they wanted further clarification on that point. No?
Adam, I guess a question I have is why is it important for us to be utilizing more of the fat and not carbohydrates? Like why is that important to our body?
Yeah, so that's a good point, Bye. Um, so this has nothing to do with what we're eating and fat and carbohydrate from that perspective. It has to do with where or what bucket within our body of energy do we have access to. Even the leanest individuals amongst us have tens of thousands of calories of fat available to us at all times. This is the near infinite energy source that we can tap into at relatively low work rates. Even those amongst us who are well muscled, because glycogen is stored in both in the liver and in muscles, if we're well muscled individuals, we might have 500 grams of carbohydrate. 500 grams is roughly 4,000 calories. And so it's a limited resource. And if at very low intensities of exertion, or even no exertion, at there are basal metabolic rate, which basically just means the amount of energy for us to breathe and our heart to pump and all of those sorts of things. We are tapping into utilizing carbohydrate more, then that obviously becomes a problem because it's a limited resource. Just in Cameron, would you?
Yes, hi. Just
Hi.
a quick clarification question. So I have done a little bit of sort of reading, I guess, or listening to like exercise science, and I
Mhm.
know that sometimes the I think sometimes they refer to the point where you're no longer using fat and instead using carbohydrates as I think the lactate threshold or the first
Yeah,
lactate threshold.
sometimes it's called anaerobic threshold. Sometimes it's called lactate threshold. It depends on what particular metric you're looking at.
Okay, so I was just trying to, is it the same concept? So are we saying essentially that that first lactate threshold is lower in people with,
It's not only lower, it's dynamic, meaning that if one exerts themselves and they find themselves experiencing post-exertional malaise, at that point in time, until they've recovered back to their baseline, that threshold has moved down lower in their intensity spectrum, or often we're measuring that by heart rate, but you could also measure it on a bike by watts, or essentially just work rate.
interesting?
And
Okay,
that's the really critical and interesting point that helps inform us on how to help people with pacing, because what it means is that what you could do yesterday is not necessarily what you can do today. And we have to understand our physiology and the engine that we're working with in order to grade our exertion and try and avoid those crashes. And this is why it's so difficult for people to avoid crashes, because we tend to trust our bodies in that if I've done it before, I can do it again. And that's not necessarily the case. Cameron, I think you'll find the next slide an interesting one. It's goes a little bit more into the exercise physiology.
awesome. Thank you.
Yeah, no problem. Any others before we move to that? No? Okay, good. All right, so this is a kind of a famous slide by a guy named Inigo San Milan. He is a PhD and researcher into mitochondrial health in the context of, he does some work in long COVID and has published in long COVID, in cancer, metabolic syndrome, and also in elite athletes. And so he's had a long career and is really a global leader in understanding energy systems and how our metabolism works. So this is a very busy slide with a lot of information on it. So I'm just gonna try and direct your attention. Vi, can you see my cursor on this screen or not?
Yes, I can
You
see it.
can. Okay. All right. So this orange line is fat oxidation. So that's our body's ability to utilize fat. The red line is carbohydrate oxidation, and the blue line is lactate, Cameron was talking about before. Orienting you along the bottom here, this 112, 121, this is heart rate. So you can think of, as we're moving from left to right, this individual is working a little bit harder and a little bit harder in terms of the demand to produce energy. So down here at the far left, this is just rest. This is you or me lying on the sofa and just breathing and existing. At that point, we're using a very, very small amount of carbohydrate, and our body typically is using uh, fat as its primary substrate for energy. As we begin to work a little bit harder, we use a little bit more and a little bit more fat. There comes a point right in around here on this graph where we've maxed out the amount of fat that we can use to produce energy. And that is now too slow. So essentially, um, in order to utilize fat as energy, it has to be liberated from a cell, run through our bloodstream, go into the cell, into the mitochondria, and it produces a lot of ATP or energy. The thing is, that's a great process, but it's a long trip. And we can only do it so quickly. And it's likely limited by the number and size of the mitochondria that we have in the cell. Once that capability is tapped out, we have to begin to rely on carbohydrates. So you can see at this point, the carbohydrate starts to ramp up and the fat begins to come down. As we produce energy utilizing carbohydrate, our body produces more lactate. Lactate is a byproduct of carbohydrate use. It is also a fuel. So our body uses lactate also for energy. But when that lactate builds up, it prevents us, or it actually blocks us from using fat for fuels. That's supposed to happen. The reason that happens is that we're telling our body, we need energy now. We don't have time for this slow process. Let's save our resources in terms of mitochondria for carbohydrate. So lactate helps with that. So all that is to say that this point, or the point at which the rate at which we can utilize fat as a substrate in people who are dealing with post-viral illness like long COVID, is moved to the left. So it's at lower intensities that fat drops off and carbohydrate spikes up. We have shown also, or others have shown in the research, that people with ME/CFS and long COVID typically have higher resting lactate levels. So that basically means they're utilizing a higher fraction of carbohydrate even at rest. So the impairment means that not only do we have a limited ability to tap into body fat as this great source of energy, the byproduct of the fuel we can use, which is lactate, we have a challenge processing it as well. And so when we have a challenge processing lactate, what happens is the local environment in the muscle becomes acidic. And that will cause a great deal of fatigue. It can cause pain and essentially shuts down mitochondrial or slows mitochondrial function. Questions about this now that we're at that? Yes, Cara.
Hi.
Hi.
I just had a question because it's still for me, I'm still trying to wrap my head around all the metabolic, more detailed stuff. But would you say that, pre-long COVID or pre-ME/CFS for another reason, when you would work out hard, you would get that buildup of lactic acid after you've done a long run or that sort of thing? And now would you say that the process that's happening when you have long COVID is even standing up is like running that marathon before, and the fatigue and stuff that you're feeling is a buildup of lactic acid in your body because that anaerobic threshold has shifted significantly to the left of what you can do, and is a sort of more simplified way to think of it is that when you stand up, you have that intense feeling of lactic acid buildup, which causes the fatigue and flares your other symptoms.
So there's a bunch in there that is absolutely correct in that you're at that lower level of exertion when you stand and move. Biochemically, it's a little closer to, pre-COVID for you. It might have been jogging or running. And the difference is that, or one of the differences, is that in that pre-COVID state, also your ability to clear lactate and to reverse that state was more efficient. And so I don't want to create the impression that this finding is a complete solution and it explains all of the fatigue and all of the symptoms. It's an interesting finding, and I think that as we look more closely at mitochondrial dysfunction and metabolism in the context of post-viral illness, we're going to learn a lot more in the coming years. And so I think that there are some, for instance, there's some early findings that pyruvate dehydrogenase, which is an enzyme, is impaired in long COVID. There are some findings out of the U.S. on certain transporters across membranes that are impaired. The challenge with metabolism is that you never know if what you're looking at is a step in the process that's impaired because of something earlier in the pathway, or if you're looking at the primary issue. And so all I'm comfortable saying here is that our ability to utilize fat as a substrate is impaired. It's shifted to the left. We're jammed up into carbohydrate use, which normally would be required or saved for higher intensities. And the byproducts of that utilization of carbohydrate, we have a challenge with processing them into energy. So lactate, we think of lactate as, or lactic acid, if you will, it's actually not lactic acid, but lactate as a bad thing, as a buildup. It's not. It's a fuel that when we oxidize carbohydrate, lactate is a byproduct, but then that lactate goes into our type 1 muscle fibers, into our heart, into our brain as a source of energy. So lactate's a good thing. It can help us produce energy. Unfortunately, in long COVID, our ability to use. Hopefully that answered your question. I have a tendency to go on and on when it comes to these things.
Yeah, no, it's all very detailed science.
It can be. Any other questions before we?
Yeah, Adam, we have a question in the chat from Crystal.
Okay.
What is the impact of medications that reduce heart rate, such as ivabradine, on this process? Does it put someone back into fatty acid burning, or is a person still in the carbohydrate lactate burning and heart rate is not a reliable indicator?
Yeah, so that's great. We are going to chat about that as well. No, the short answer is no. Lowering your heart rate utilizing a beta blocker doesn't really change anything at the base metabolic level. What determines what substrate we're using is our intensity of work and our mitochondrial resources. Heart rate can be a poor indicator if you are an individual who has dysautonomia or POTS. There are lots of reasons why your heart rate can go up. In this particular example, what we're looking at is heart rate as a proxy for metabolic demand or work. Whereas sometimes we can get heart rate elevations due to postural orthostatic tachycardia syndrome, which has nothing to do with work, really. It has to do with other factors. And so lowering one's heart rate using ivabradine or a beta blocker, I would not expect to have an impact on this point, because it's not lowering the amount of work you're doing and it's not changing our ability to process those fuels.
Okay, and another question.
Any others before we move on?
Yeah, another question is there a way to know where your switch changes? 10 minutes ago,
Yes.
I walked from the bedroom to the kitchen and back. Is the burning in my legs lactic acid? Anything I can do to reduce the burn time?
Yes. So we are going to get into that. The science is one thing, the practical application is another. There are things that happen at this point. And for individuals whose heart rate is a reliable indicator and they don't have dysautonomia, you can use heart rate. For others, there's a convenient thing that happens here. When you begin to burn more carbohydrate, your body produces more CO2. And when you produce more CO2, your respiratory rate has to go up to clear that CO2. And so if we watch our breathing to ensure that our respiratory rate has not noticeably elevated beyond our normal resting rate, we can be sure that we're kind of below that threshold. And so that's something we call RT1, or respiratory threshold 1, which would occur very close in relationship with this point. And the beautiful thing about that is that when this point moves, so too does that RT1. There's also an RT2, but it occurs way up here when people are working really, really hard, which I don't recommend. And on the burning, again, the lactate isn't causing the burning. It's actually the hydrogen ions that come along with lactate. And locally, the muscle becomes a little bit acidic, and that's the burning. And so rest, sitting down or stopping the onslaught of energy demand is the best way to eliminate that. There's not really any other great way to do that other than just it will improve with a little bit of training, so long as that training occurs at your level. Any others before we move on?
Yeah, we have one more, which you might be touching base in the next few slides. It's what data do you suggest we track with wearables?
So we're going into that.
Yeah.
For sure. So I'm going to get to that data piece. So I'm going to park it for the moment so that we don't hit it twice.
Sure.
So just from a discussion perspective, how does this understanding inform our treatment planning in long COVID? And somebody's already kind of leaped there to touch on it. What this has taught us is that pacing may be less about how much you do and more about the rate of energy demand. So as long as the rate of energy demand is at or below a level that we can manage, especially utilizing fat as a substrate, then we're less likely to push into PEM and create a crash. That doesn't mean that we can't exceed that level sometimes, but the point is that when we exceed that level, we want to do it for an appropriate time frame. We don't want to live there. We won't, if I climb the stairs, I'm going to burn carbohydrate for sure. But then I'm going to rest and bring it down, and that whole thing will take 20 seconds. If just walking on a particular day because you're experiencing PEM has you above your respiratory threshold and you walk for a fairly long time, that's a little bit riskier. Whereas on another day, you might find that walking doesn't have you above your respiratory threshold. And you could easily speak in sentences, and if you were talking on the phone, no one would know that you were exercising in any way. That's how you know you're down in that intensity zone, that your system is capable of meeting the energy demands at that lower end on the left side of the scale. If you understand that this point is dynamic, how do we go about testing it? So in any given day, we wake up and we have a bunch of things that we would either like to do or need to do. And pacing is all about spreading those things out in a way that we can accomplish as much as possible while minimizing our risk of crashes and symptom flares, right? Well, if on a given day when you get up, if you have a standard test, meaning maybe that is a short walk around your house, depending on who you are, it'll be different, right? Like people whose energy systems are functioning higher, it might look a little different. For some people with long COVID at the beginning, it might be sitting up in bed. But if you can test that and pay attention to your respiratory threshold and pay attention to what's happening to your heart rate, those things may inform what you can do that day and where your system is at. Okay. There's another kind of exciting little device that we use at Cornerstone for a bunch of things, more in our metabolic rehab program, but there is a way you can actually measure this and know at rest what you're burning, which is, I think, it would be a really interesting study in long COVID, but hasn't yet been done with symptoms and with biometrics and everything. We have this huge treasure trove of data. What we've noticed is that people who are suffering from that ME/CFS phenotype of long COVID seem to be at greater risk for developing metabolic syndrome. So things like fatty liver disease, hypertension, type 2 diabetes, in individuals who you wouldn't otherwise suspect that. And that may be linked to the challenge with oxidizing fats. And that's just an observation that needs to be handed to the academic community to be studied more closely, just to be clear. Okay, so wearable tech, and this is where these two things kind of come together. How do we use it? It's important that when using wearable tech that we understand what we're looking at. What are these data points? How reliable are they? And understand that there's some noise in there. Like wearables aren't perfect. And for that reason, trends can be valuable, but single values are rarely valuable. We use it in two ways. It can be predictive, meaning there are certain metrics that we watch for trends that might say to us, hey, we should really slow down. We're risking a crash here. Some examples of that would be like increasing resting heart rate or minimum heart rate, or a declining HRV. Not one low value, but average HRV coming down over days would be indicative that maybe we should slow down for a bit and let things recover. And then in the program, we also use them prescriptively. So any of you who have, say, an Apple Watch, and you can look down and see what your rings are doing for the day, we can set those. So we can set an energy budget for the day. We can also have these wearables report our heart rate to us as we move through our day, trying to stay below a certain threshold. And overnight tracking can be useful, looking at like respiratory rate during sleep. That can be a predictive. So on the wearables, on the prescriptive side, at Cornerstone, it allows us to move people through their program in small increments of increased function while monitoring symptoms to ensure that we're not exceeding their abilities and we're not risking worsening of their symptoms. Now, long COVID being long COVID, it can still happen. People can, as anyone who has dealt with this condition knows, we have stress, we have cognition, we have mast cell activation syndrome, and we have physical activity. So we got to kind of trying to control all of those things to avoid 100% of crashes is a real challenge. But whenever we're increasing function or physicality, we do so in very small increments and monitor the response. And wearables allow us to do that. So the metrics that are of interest, resting heart rate, important to note on wearables that sometimes they just think you're at rest. And it's always best if you're doing a resting heart rate to do it with discipline, meaning either you're seated comfortably or you're lying down for 5 minutes and then check your heart rate. Whereas sometimes, your wearable may just think you're at rest and it'll report a resting heart rate that's a little bit high. For that reason, I like the second one better, minimum heart rate. So in a given day, what was the lowest resting heart rate? That gives me a good idea of where an individual's system is at, and if they are experiencing high sympathetic drive, or if they are risking a crash, getting almost to like an overtrained state, that minimum heart rate will begin to track up. We can use active cals and or steps to help with pacing, just to give a budget for a given day. And then I want to talk a little bit about HRV, because HRV is poorly understood. Our HRV stands for heart rate variability. It is the variability in the interval of time between heartbeats. So an HRV of 0 would be if you had a heart rate of 60 beats per minute and the amount of time between each heartbeat was exactly the same. It was 1 second. You could still have a heart rate of 60 and have some that are long and some that are short, and your HRV would be bigger. So it's the variability in that gap between heart rates. Now, wearables love to take HRV samples whenever. And they report to you the most recent number as though it's meaningful. It's not. When I'm at rest and my heart rate is as low as it's going to be that day, my HRV that day or on that reading will read high. When I am physically active and my heart rate's higher, it's going to read lower. And what's more important is if we take a disciplined resting heart rate and measure the HRV at that time and compare that day to other days to have an understanding of where your autonomic nervous system is at. If you have a low HRV or it's lower than normal, it may indicate that a higher sympathetic component to your autonomic nervous system, which could mean you're heading toward or at risk for a crash if we don't compensate for that. So how we use HRV matters. The best one that I like is the overnight average. If we have a wearable that you wear at night and takes a running HRV all night, and I can get an average value, that's very useful. And that's the one that we tend to focus on in the program if we're going to use HRV. Sleep quality and efficiency. Oftentimes, people with long COVID have challenges with sleep, and their efficiency in particular, meaning the amount of time they're actually asleep, or the percentage of time they're actually asleep when they're in bed, tends to be a precursor to symptom exacerbations, as does sleep respiratory rate. And so if your wearable reports that, you get up in the morning and you're normally 12 breaths per minute pretty consistently, and you were 15, something to work into your pacing for that day. To think, my system might be under stress. It might be best to push a couple of things or make adjustments where possible. We can also look at active minutes or minutes above a certain heart rate threshold. And then the other great tool is just a timer. And so in particular, people who have POTS or postural orthostatic tachycardia syndrome will have them use a timer just as an alarm to go off to make sure that they get supine at various intervals through the day to allow their system to recover from that upright posture that tends to produce a lot of sympathetic drive as well as symptoms for them. I'm going to pause there and allow people to ask some questions in case.
Yeah, one of the questions, Adam, is do we have access to the data you see at Cornerstone from our wearable devices?
Yeah, everything that we see is, of course, comes through the device. So it'll be in your, each device is different. So Apple, it's in Apple Health. In Garmin, it's in Garmin Connect. And in Fitbit, you have an account that you can look at. As long as you know what you're looking for, you can go in and find this data. In Connect, we've organized it in such a way that it's meaningful to the clinician and can be helpful. And we can look at it against their symptoms as well as look at any metric against another metric and see how they're trending together. And so it does provide insights for us that is difficult to get in a dashboard made for a consumer wearable that is for everybody, usually tuned more toward fitness or wellness than pacing or chronic disease management. But all the data is there for sure. And so if you wanted to, in any of, say, Apple Health, you can go in and find your sleep respiratory rate over the last week, month, 6 months, and be able to see what it is. I would recommend, if you're going to do that, to also log somewhere your symptoms. And you can begin to see how the relationship between those two things. And you'll find out which metrics for you are meaningful, because not everybody responds exactly the same way. For some people, HRV will be very sensitive and useful. In others, it'll be sleep respiratory rate that tracks better with their symptoms.
Okay. And another question was, do you feel the more advanced Garmin watches have more advantages in managing symptoms better?
No. They're mostly packed full of wonderful features for triathletes. They have the same quality sensors in the lower end Garmin items. Sometimes what is available at a glance on the screen is a little better in the mid to higher range, but the lower end of Garmin devices are high quality devices that provide accurate data. The same cannot be said of Fitbit, but in Garmin's case, that is true.
Adam, what happens in the case that a watch does not provide an HRV reading?
Then I would simply, you know what, on this page, HRV is a really interesting metric and it's highly sensitive, but it's also full of confounding variables. I would simply use minimum heart rate, or I would use sleep rest rate. I wouldn't worry too much about it.
Good to know. Another question is, how can this information be extended to cognitive and emotional energy use? Cognitive energy use can definitely cause PEM, but it does not affect my respiratory rate the same way that physical energy use does.
Yeah, it's certainly a challenge to capture and quantify that. That said, your brain is existing in the same biological system as your body. It may not produce increased respiration from cognitive effort, but if you are at risk for a crash from lots of cognition and stress, you will see certain other static metrics move, like the minimum heart rate, like the overnight respiratory rate, or the HRV. So there's still a response. It's just not in the moment causing enough CO2, because it's just a relatively small amount of tissue, to have to increase your respiratory rate.
Good. And are active minutes a useful measure in someone who has POTS, or is that totally useless?
It can be. We have gone to efforts to quantify it, and I wouldn't use active minutes in the sense that I look back on my day and try and calculate it, but rather I would do, if you're familiar with a 10-minute stand test. So our website at Cornerstone, we have a blog, and you can just put in POTS and you'll see a great example of how to do a 10-minute stand test. On any given day, if you do a 10-minute stand and you can say, okay, well, my heart rate at rest, or when my standing heart rate is X, then you're going to use, 15 or 20 beats above that as your ceiling. So use like a heart rate ceiling. That does help in POTS. Now, POTS is more dynamic than that. It's not perfect, but I would encourage you, I think the best way to pace on the basis of the science that we have right now is to begin to understand how much energy demand I'm producing with what I'm doing. And if I slow my task or break it up in a way that I'm not asking a lot of my system over a relatively short period of time, I'll actually overall be able to get more done. And so beginning to think of it in terms of that would be helpful. Not to suggest it's easy. It's just the best we know how to do right now.
Question on sleep apnea. Does sleep apnea impact sleep respiratory rate, and how useful of a metric it is for long COVID?
That's a good question. I can't imagine that sleep apnea wouldn't impact respiratory rate. But I still think that producing a baseline, because your sleep apnea is not changing depending on what state you're in, having a baseline and then a remeasure is probably still valid. The only thing is if your sleep apnea is positional and you're sleeping in a different position one night versus another, it's gonna then you might, if that were my case, then I might investigate minimum heart rate instead.
Okay. And last question on from Karen. Do you have access to visible data?
Visible being the app Visible?
Yeah.
No. So what Visible does something similar to what Connect does is that it uses your wearable and pulls data into it. And so we have an app that you connect your wearable to, and we can set up symptoms that you're going to monitor, and each day you monitor it and it pulls it all in. So we're both aggregators of the same data. There's no reason that if you have a wearable that's connected to Visible, you couldn't also connect it to Connect. So.
This is a good question. What are you most excited in long COVID treatments that we may not have heard about yet?
Oh. Well, I think that there's actually a whole bunch of interesting work being done at the mitochondrial level. I also think that there's interesting work being done looking at substrate utilization and being able to measure that at home. You know, there's so much going on. There's taurine levels that have come up. There's a lot of stuff being investigated. None of it coming through just yet, but I believe if you're asking my opinion, what I think is going to be a breakthrough for people, I think it's going to probably be a pharmacological breakthrough and it'll be at the level of the mitochondria, helping. We've been after that a long time, but I think that the scientific community has made some real strides in that area. Also, there's a trial that's going to start at UHN in the coming months, hopefully, on hyperbaric oxygen, which I think is interesting because some of the early trials on that have been very helpful for people. So, next slide,
Yes, next slide.
So, I mean, we've covered this, but trends to pay attention to: a rising resting or minimum heart rate, elevated overnight rest rate, a trend of reduced HRV, not one low value. Don't worry about one low or high value ever. And decreasing sleep efficiency are things that might indicate that a period of rest would be best. So what wearables? Just as a quick comparison, Apple, $3 signs. Apple's not cheap. But older generations work just as well as the newer ones, and you can often pick that up. They have a very good interface, very good sensors. They have that convenient 3-ring structure where you can use that to pace, full day battery life, and it's a very full-featured platform. If you're not an Apple user or you're looking for something a little bit less expensive, Garmin is probably the next best option in my view. You can get lower price options, and as I said, you know, they're great. The sensors work well, and the data's good. And they have a decent interface on the watch face for pacing. Aura, very expensive device, also requires a subscription, which makes it that much more expensive. It is excellent for sleep tracking. There's nothing you can look at on your Aura ring for pacing. Unfortunately, you have to open your phone and then sync it to your ring. It's a bit of a pain. And it's not great at activity monitoring. So it does do all day heart rate, but it doesn't do it well. And then Fitbit is our least favorite device. They are lower cost, although the lower end of Garmin is similar. You do need a subscription often to get the full features around HRV and that sort of thing. But again, I would just use one of the other metrics. Don't pay for the subscription. The sensor quality is not great, and its interface for looking at data is a little buggier. Any questions about devices? Any I didn't cover that people are interested in?
Nope, you covered it. But there's a question on sleep efficiency. We can hold it off until you're done
No,
this.
go ahead.
Okay.
So,
Is sleep efficiency well measured by wearables? My wearable, a Fitbit, usually says I'm waking up at times when I do not recall being awake.
yeah. So it's hard to say whether if we put a camera on you, like most of the time, we don't necessarily remember every time that we wake up and then fall back asleep. Um, Although my suspicion on Fitbit, like I don't have a lot of trust in Fitbit data. My Aura and Apple data, as it pertains to sleep, I think is quality as long as I'm looking at are you asleep or are you awake? It can answer those questions well. I would not read into sleep stages as they are measured by a device. I don't think they're good enough at that. So if you happen to dig into your data and say, "Oh, I haven't been getting any deep sleep," then don't worry about that. It doesn't matter. But all of the Garmin, the Apple, and the Aura, I think, are good at knowing if you're awake or asleep. But I share your concern about Fitbit.
And what about the Pixel watches? Are they better than Fitbit?
Yes. And in my experience, they're decent. They're probably after Apple, Garmin, and Aura, but not Fitbit. Clearly, as you might have noticed, I have a thing with Fitbit. After 5 years of developing this program, we fallen in love with Fitbit. So interesting advances that are coming. Addition of blood pressure monitoring into a smartwatch seems to be coming. Apple, I think, is going to introduce that in the next couple of generations, it seems. And there are a few other wearables that do it at the moment, but maybe not. It might not quite be there, ready for prime time yet. There are devices coming that have at-home ECG recording and interpretation, utilizing neural nets and machine learning, which is really interesting in a ring form factor. And then this is called a caliber. This is a mask that actually measures the CO2 produced and oxygen consumed and can tell you what substrates at any given time you are burning. These are commercially available from the US. They're not inexpensive. I think they're 700 and something US. But if you were able, the price will come down, of course. But if you were able in a morning at rest to sort out where you were and then maybe just see what your walking substrate utilization was, that would be a really interesting way of quantifying what it is that we're talking about. So I think that something like this down the line will be really useful for people dealing with COVID. The other one that, if you've been a part of Cornerstone, you might have been exposed to is heart math. And that's HRV biofeedback, where we have a little clip on the ear and we do breathing exercises. And on a phone or an iPad, you can see the fluctuation in your HRV and tune your breathing exercises to be able to be very effective at increasing parasympathetic drive and all that sort of thing. So really great. And I mean, that's, I guess, not an advancement. HeartMath's been around a while. It's just a lot of people don't know about it.
There's a question not particularly on wearables, but it's would you recommend red light therapy for mitochondrial function? From what I've heard, it sounds similar to the benefits of hyperbaric oxygen, but much more affordable.
I'm just going to say I don't know enough. I've looked at some of the research on it. I haven't seen research from what I would deem to be like a high quality trusted source. And so I'm a little tenuous, but I look forward to hopefully seeing more. But it's not something that first off, I don't, when it comes to people seeking things that might help them in long COVID, I'm not here to tell you it's not going to work because we don't know what works. And we also have things that will work for some people and not for others. But I guess what I would say is just that the jury's out from an evidence perspective on that.
Another question is, are you aware of the Lumia device for dysautonomia that is under development in the US, which is an in-ear wearable that measures blood flow to the brain along with other measures?
I'm not, but I'm intrigued.
It's called Lumia.
Lumia.
Yeah.
That's interesting. There's also there's a device that is a collar that is used for people who have POTS that puts a little bit of pressure on the jugular vein and helps with maintaining pressure in the brain. One of our famous cardiologists in Toronto was involved in developing that. I've had patients use it, called a Q collar. Interesting, like positive results, although I think very difficult to continue with for a long term. I do think that if the hyperbaric oxygen stuff bears out, that we will begin to see a lowering and an increase in availability, hopefully. It is obviously difficult to access at the moment.
Good.
This is just a screenshot of Cornerstone Connect. This is my data, so it's just a demo account, but kind of shows how we can look at different things against one another. These drop-down menus, I can pull up everything from, everything a wearable brings in or a nutrition app brings in or symptoms, all those different things, and see them in the graph and be able to look at relationships. We have a place where we add symptoms that you would track in your app, and then we get a summary of, in this case, over the last 13 days that I tracked nutrition, how were those. We can go into a single day and our dietitians can see, not only the macronutrients and micronutrients, but what exactly were you eating. And so they can help people with food sensitivities and that kind of thing. And so what we've really tried to do is build in all the sources of information that are available to us to try and coach and help people. And it's a work in progress. It continues to evolve. Any questions about that?
Questions in the chat? No.
Okay. That is the end of my slideshow. I'm happy to, stick around and answer any questions.